Low dose dopamine, 2 to 3 mg kilogram minute, increases renal blood flow and glomerular filtration rate, resulting in effective diuresis and natriuresis. This will lower filling pressures, reduce lung congestion, and improve oxygenation. It has been shown to be clinically beneficial while reducing the need for diuretics in postoperative patients with normal renal function. However, one study found that low-dose dopamine was able to increase renal blood flow only in patients with normal renal function. If moderate impairment was present, inotropic doses of dopamine were required to improve renal blood flow. Thus, in patients with normal renal function, dopamine may improve urine output and provide some clinical benefits, but there is no evidence that it improves outcomes or has any impact on preventing renal dysfunction. The same holds true for diuretics. Guidelines for the hemodynamic and fluid management of typical postoperative scenarios are presented in Chapter 8. Prevention of acute kidney injury. The risk of developing postoperative acute kidney injury is very low when a patient with normal renal function undergoes an uneventful operation and maintains satisfactory postoperative hemodynamics. In contrast, the presence of any degree of preoperative renal dysfunction increases the risk of postoperative acute kidney injury and mortality. Therefore, it is important to identify patients with preoperative renal dysfunction and those with other risk factors for developing postoperative renal failure. Definition of preoperative renal dysfunction. Renal dysfunction is commonly defined as a serum creatinine more than 1.5 mg deciliter or more than 130 nanogram mole liter. 1 mg deciliter is equal 88 micromole liter. However, the serum creatinine is not an ideal means of assessing kidney function because it may be normal with a greater than 50% reduction in glomerular filtration rate, which reflects the number of functioning nephrons. A more sensitive estimate of renal function can be obtained using the creatinine clearance in milliliter minute, which approximates the glomerular filtration rate. This is more indicative of renal reserve and the ability of the kidneys to tolerate surgical stress. A glomerular filtration rate below 60 milliliter minute, 1.73 meter square, is the best definition of renal dysfunction and is the level below which there is an increased risk of worsening renal dysfunction and increased mortality. A 24-hour urine collection to precisely measure the serum creatinine is considered to be no more reliable than an estimate using one of the following two predictor equations. The Cockcroft and Quelt equation can easily be calculated at the bedside and is generally indexed to the patient's weight. One study concluded that this formula was better than the MDRD formula in predicting in-hospital mortality. Serum creatinine clearance 140 minus age, weight 0.85 if female, 72, and serum creatinine. The 2005 modification of diet in renal disease formula appears complex but is used in most laboratories to provide a Geffler estimate. It is usually considered to be a more precise measure of abnormal renal function. Glomerular filtration rate is equal 186. Serum creatinine age 0.742 if female, 1.210 if black, where glomerular filtration rate is equal milliliter minute 1.73 square meter, serum creatinine milligram deciliter. The importance of pre-existing renal dysfunction. An elevated preoperative creatinine, or more specifically a reduction in creatine clearance or glomerular filtration rate, is the most powerful predictor of acute kidney injury after surgery and is a major risk factor for operative mortality. An analysis of nearly 500,000 patients in the Society of Thoracic Surgeons database confirmed an increasing operative mortality with progressively lower glomerular filtration rate of less than 60 milliliter minute 1.73 meter square. Defining the degree of renal dysfunction by glomerular filtration rate as recommended by the National Kidney Foundation guidelines, the mortality rates and requirements for dialysis in this representative analysis of patients undergoing coronary artery bypass grafting are shown in table 12.1. We are going to the table 12.1, mortality rates and dialysis requirements according to the degree of renal dysfunction. Degree of renal dysfunction: if it is normal, GFR is more than 90, mortality is 1.3%, new dialysis 0.2%, stage 1 if albuminuria. Mild renal dysfunction, GFR is among 60 to 90, mortality 1.8%, new dialysis 0.5%, stage 2 if albuminuria. Moderate renal dysfunction, glomerular filtration rate 30 to 59, mortality 4.3%, 1.8% new dialysis, and stage is stage 3. Severe renal dysfunction, glomerular filtration rate below 30, mortality is 9.3%, new dialysis is 10.9%, stage 4 to 5. Dialysis, GFR is known, mortality is 9%, NA, and there is no stage. An assessment of GFR is very helpful in identifying patients with a milder degree of renal dysfunction, which is also associated with adverse renal outcomes and greater mortality. Even patients with so-called occult renal insufficiency, serum creatinine below 1.1 milligram deciliter with a glomerular filtration rate below 60 milliliter minute, which is noted in about 13% of patients with a normal serum creatinine, have significantly higher mortality and renal failure requiring renal replacement therapies than those with normal renal function. Smaller studies correlating serum creatinine levels with mortality have shown somewhat however mortality rates than those demonstrated in the CTC study. Generally, the mortality risk for coronary artery bypass grafting patients is about 5% for patients with serum creatinine 1.5 to 2.5 milligram deciliter, 15 to 30% in non-dialysis dependent patients with serum creatinine more than 2.5 milligram deciliter, and 10 to 15% for those on chronic dialysis. One study found that the risk of acute kidney injury was increased 4.8-fold for each 1 milligram deciliter increment in serum creatinine. Another found that the risk of dialysis extended 30% if the preoperative serum creatinine was more than 2.5 milligram deciliter. It is best to use the available risk models to individualize the risks of acute kidney injury and renal replacement therapy based upon an assessment of all contributing risk factors. The operative mortality for patients who develop acute kidney injury that requires de novo dialysis ranges from 40% to 60% in several large series. These alarming statistics emphasize the crucial importance of taking any steps possible to preserve renal function in the perioperative period, especially in patients at